Good afternoon, everybody. So it's a pleasure to talk to you, and thank you much for the invite to talk with you about outcome measures in AGS and in general, a little bit more of the process that it's determination of natural history in rare conditions and how to select and design outcome measures that can be used in the context of longitudinal natural history or the evaluation of clinical trial efficacy, and in general, what are the challenges, the specific challenges associated with trying to understand what works in rare conditions. Is it the controller of the...
So it's on the second screen. So you probably have to put the mouse over there and then hit down. So just use the keys.
Okay. So this is these are my disclosures. The research that I work upon and myself are supported by a NIH grant. So the outline of the presentation is going to include a little bit of an introduction for what is AGS, and I will just fly through it because it was done quite beautifully already in the presentation before, and then I will describe a little bit the natural history of AGS and what are the outcome measures that we use currently in our research program and why we selected them. And I will show you also some preliminary data, and some of that is pre-publications. Some of them are going to be included in publications that are going to come very soon. And then just a super quick insight on the therapeutic intervention of AGS that was conducted at CHOP and the application of outcome measures in that context. And then just a quick idea on clinical recommendations in AGS, what to look for, and what are potential evaluations that somebody should do as a follow-up. So just a couple of slides with a lot of pictures of all the people that are involved into the research project. There are a lot of people. It's a very, very numerous group, and everybody has a unique expertise, and everybody is extremely motivated and extremely focus on the project, and this will not be possible without the extreme support, insight, and guidance of Dr. Van der Ver and Dr. Edeng. And in parallel with the research group, there is also a clinical team that cares for children with AGS, and you will see that some of the people are playing double, and so that it's even more interesting because these are people that have incredible insights also on the research aspects of the project, and these are the main people involved. There is a flurry of other people that collaborate with us, but I didn't have the pictures of everybody, so this is who I was able to include. Okay, so AGS, as mentioned before, is a early onset inflammatory disease that is genetically inherited, and there are numerous genes involved. At the time I created these slides, there were 9 genes. Now there are actually 10. One was published like a couple of days ago, and so you see that it's a process that it continues evolving, and the clinical manifestation of AGS are extremely heterogeneous. While there is almost always involvement of the central nervous system, there are also a lot of recurrent symptoms that are associated with multi-organ involvement, and you can have skin problems, you can have liver problems, you can have blood problems, cardiac problems, muscle problems, so it's extremely heterogeneous. And as mentioned before, there are some neurologic signs and neuroradiologic signs and symptoms that are associated with this condition, even if now we know that they are not always present, because originally there was a classic phenotype as described before, and so basically it was more likely to find and diagnose a child that had only that specific manifestation, but now we are aware that the phenotype is expanding dramatically, and so we need to be a little bit more creative when taking into consideration the possibility of a suspect of a diagnosis of AGS. And the pathogenesis was like already covered before, so I will not discuss about it. And one of the tools that we use as a biomarker is the interferon score, which is basically the measurement of the expression of genes that are activated by interferon that is circulating all over the body. And so it's an indirect measurement of the activity of the interferon. And this is a tool that was started to be applied about 10 years ago at this point, and it's now undergoing process to facilitate standardization and comparison over time. Treatments available for AGS, as discussed before, there are multiple potential ones. The one that I'm going to focus during this presentation is going to be JAK inhibitors, that, as mentioned before, it's basically a drug, that a molecule that tend to block the receptor of the interferon, the expression of the cascade, the cellular cascade that is associated with the link of the interferon molecule with the receptor on cells. Okay, so natural history of AGS. So about at this point 4 years ago, we published one of the first papers that were exploring in depth developmental trajectories of children and teenagers with AGS. And this first study was including about 100 individuals from different centers worldwide. And what we tried to determine was what were potential symptoms that were associated with a more or less likelihood to acquire specific milestones. And these milestones were including motor milestones, but also communication milestones, even if mostly verbal communication, and also some social or more cognitive skills. And so we were able to determine that there is a great variability, and there are some genotypes that are most likely to be associated with a more severe manifestation of the condition, but that's not for granted, and there is a lot of variability. There is a lot of spectrum, as shown before. Individuals with the same genes, potentially with the same gene mutation, can actually present very different clinical manifestations. And the studies that we're conducting showed that AGS was originally described as an early onset condition, but actually there are also situations in which AGS can have a late onset. And there is also a difference with what was traditionally described. So originally it was described as a condition for which a child is developing relatively typically up to a certain point, and then there is an acute event associated with a regression, and then there is a more stable phase. But actually what we were seeing is that particularly in the situations in which AGS has an onset in the second, third or fourth year of life, there are maybe some very mild signs that might raise an alarm if somebody really looks into that, but it's mostly a post-hoc analysis that we do. So it's like, well, maybe my child at 6 months was not really sitting, maybe was sitting more around like 7 or 8 months, or maybe ambulation was a little bit delayed or a little bit unsteady, but it was not something that really was of concern for us or for the pediatrician that was doing the well-being visits. And so we were able to show that there are specific genotypes that are sometimes associated with a later onset compared to other ones. And we were seeing that particularly in SAMHD1, IFH1 and ADER1, this is something that occurs relatively often. And now we are in the process of conducting a natural history study of AGS that is led by Dr. Deng and Dr. van der Ver. And basically, this currently includes more than 160 individuals in which information about medical complication and medical events are collected in a very rigorous way, and in this way we can try to get a better sense of how likely is to have potential complications, what are symptoms that should raise concern for a diagnosis and early referral from a pediatrician to a child neurologist that has a knowledge in potential leukodystrophies, and also how to better streamline potential preventive care that is typically much less invasive than interventional care later on in life. And this is an ongoing study. Hopefully, by the end of the year, we should be able to publish and disseminate this study. Okay, now that said, it's important to create a little bit of a common ground on what outcome measures are. So outcome measure or outcome assessments are measures that describe or reflect how patients feel, function, or survives. And it's very important to frame the different types of outcome measures that there are, because they are extremely relevant, particularly when we're talking about a population that is a pediatric population. So there are patient-reported outcomes that are basically assessments that are conducted typically with the patients, but in a pediatric population with parents. And basically, directly, people can can provide feedbacks on how their children are doing in general. And this can be administered with the intermediation of a provider or directly by families without a filter. Then there are clinician reported outcomes. So basically, parents report to a clinician what a child does or how a child feels, and then based on specific guidelines, a provider can score an assessment, and that, for example, is the case of the AGS scale that was mentioned before. We have observer-reported outcomes, so basically there are inventories in which we observe some symptoms and we mark them as existing, and there is the performance outcomes group that is basically I'm asking a child to do a specific movement, a specific action, and I measure how good they do it. You already see that there is a bias in this. Compliance in children, particularly young children, can be extremely varied, and we know that in children with AGS, not every day is equal to the previous or the later one, and so we need to take in consideration also that aspect that's increased by quite a bit complexity. And one other aspect that we need to take in consideration is floor and ceiling effect. What are these? So basically these are two effects that we try to avoid as much as possible, because there are basically two effects that come into play if we choose the wrong assessment to evaluate a child. So if I choose a test that is too easy, everybody does perfectly to it, and everybody scores the maximum, there is a ceiling effect. Everybody is up in the graph, but I'm not able to discriminate as well between one child and the other because the test is too easy or not sensitive enough. But on the opposite side, if I choose something that is too difficult, everybody performs at a relatively low level for what the assessment captures, and so I'm not able to capture changes, and I'm not able to discriminate individuals. And so we try to avoid both of these. And outcome assessments that suffer of this effect, these potential effects include assessments that evaluate motor abilities, gross or fine. And by gross, I mean how a child moves around, walk, is able to sit, is able to hold their head. Fine motor, more manipulation, cognitive and psychomotor abilities, how my child think and is able to learn new things and basically put what they have learned into action. Adaptive behavior abilities, how my child is able to adapt to what the environment is asking them. Do they find alternative strategies if they cannot complete something in a traditional way? And then quality of life, which to some extent encompass everything that I've said so far. Once we have outcome measures, in rare disorder, we need to go through a process of validation, because we cannot just decide, oh, I think that this might work, and just apply it and just decide that it's the appropriate measure. We need to validate it. So once a measure is potentially selected, and selection of outcome measures feed from the natural history, because we have an idea of what are the trajectories and what are the challenges of children affected. These then go through a process of phase validity, which literally means that a group of experts sit together and they look at each other and say, okay, I know the condition, I know the tool, I think this might work. I think that this is appropriate. We don't know what's going to be the potential performance of the assessment itself, but at least we can say it's appropriate to try it. Then we administer this measure, and one of the things that is most important is to try to do in a rigorous way as much as possible. So I need to do this every 6 months, I need to do this every year, because I can really track changes over time. And then there is a process that is very complex of analysis and interpretation of the data, and then the dissemination of these. And this process is extremely important. It's extremely important for the validation of a measure, because if any one of these points is not reached and is not completed in an appropriate way, the validation process fails. And this validation process can be done with the help of clinicians, families, or the ideal way is having a mix of the two groups that basically discuss together and collaborate in the effort of administering these assessments. And one element that is even more complicated is that the validation process that is typically done in general for various conditions, it's even more challenging in individuals with rare condition, just because there are not that many children that we know that have this condition, or more likely there is just another diagnosis of children, teenagers and adults with this condition, and so it's very, very challenging to complete these studies in a reliable way. So it's very important to expand as much as possible the cohort of individuals to avoid biases, over-representations, and so on. And so we basically, the process is similar with one other aspect, that is ideally identification of biomarker to facilitate the recognition and enrollment of individuals. And basically, once you have enough data from a rigorous natural history process, you can try to bypass sort of the limitation of clinical trials in rare condition, which is the fact that it's almost impossible to do a case control study, clinical trial study. So what does that mean? Typically, a clinical trial works in having a lot of people that look alike for a lot of variables, and I divide them into two groups. Everybody's blinded. One person is receiving treatment, one person is receiving placebo, sugar basically, and you see what's the difference in the two groups. In rare condition, we don't have the luxury. And so what we do is basically taking the natural history data and using it as a non-concurrent comparator arm to the treated population, which, depending on the inclusion criteria of the clinical trial, can be the entire population or can be a subgroup based on the molecule that is chosen. One element that we focused a lot in our research was determining the impact of disease from a family perspective. And so we conducted multiple rounds of assessments that explore these. And the first one was an interview that was done with families. So we sat down together with one parent, one caregiver, sometimes even two for each child, but in an independent way. And we went through an interview that was very, very loosely guided, but was mostly like open-ended questions. And we tried to understand what was the impact of this condition on families, and in general, what were the more important concerns, but also what was the impact of disease on the child, the family, the network around the affected child, and then what were potential support mechanisms that family were relying upon, and what were hopes for the future. That basically was, what would you hope that would make an impact in changing your, improving or modifying your child quality of life. And so basically we were able to see that there were important areas coming up, mostly motor and cognitive abilities, and what we were seeing is that a lot of families were providing the feedback that even small improvements in the some of these areas were going to be considered extremely important and meaningful, and that despite the heterogeneity of manifestation of AGS, the themes were common, were coming up commonly. Then what we did was basically trying to explore what was the impact of disease of families through surveys that were emailed electronically to families, to see if these tools that are non-specific for AGS were actually able to capture what these interviews were bringing up. And actually, we were able to show that that was the case. So basically there are multiple tools that we applied, and some of them were more appropriate than others, because some of them were more able to capture the impact of disease in the population without falling into the floor effect that I mentioned before. And so these are a little bit of like busy figures, but basically the figures on the right shows the performance at the CP child, which is actually the assessment that is proving to be more appropriate, because it's able to capture the variability of function, but also the desire of families, because there is a section in this tool that actually allow directly families to express priorities and what would be important in the change of their child quality of life. And then we explore the impact of the condition on caregivers, and we use multiple tools also in this way, and we were able to show that the PISQOL family impact module was actually able to capture that there is an important impact on the life of caregivers of individual affected, and the expanded network, so like siblings, grandparents, etc., and that there is an emotional impact of families that sometimes it's difficult to verbalize. And we were seeing that there is on the right, one of the elements that was coming up the most was emotional suppression. So basically inability to be able to communicate emotional stress or emotional impact associated with these, the need to care for a child that has a diagnosis of AGS, and the challenges associated with that, but also the enormous strength that is required to do so. And basically we have been able to select two tools that are going to be applied prospectively to see if there is a change over time of priorities and in general on the impact of disease. AGS severity scale was described before. It's basically a tool that was designed as a severity scale, and that is comprised of multiple items that explore neurologic function plus head circumference, and it's a tool that is proportional with other assessments that are non-AGS specific, and so that was basically a process of validation of the tool. And basically this tool, as mentioned in the discussion before, showed how much heterogeneity there is in this population. And also, just to coming back to what I was mentioning before, the AGS scale is a tool that is designed to have sort of a ceiling effect, because it focuses mostly on motor function and cognitive function and communication function that is acquired within the first 2 to 3 years of life. And so, which is actually one of the elements that is more challenging to be captured in traditional testing, just because the floor effect is more strong by taking into consideration that function when you have a test that is basically applied in the entire pediatric population. And the AGS scale showed basically a dynamicity in children that have onset of the disease early on, and in general it tends to be very, very fluctuating in scores in the first 6 months to a year of since the disease onset, and then there is sort of a plateau. There is still some movement, but it's quite limited, and this will come in handy later on. Now I will show you some of the preliminary data that we have on different aspects of function that we're exploring in children with AGS at Children's Hospital of Philadelphia. So the first tool that we use to explore a gross motor function is called GMFM88. This is a tool that was created to explore motor function in children with cerebral palsy, and it's a tool that explores motor abilities that go from lying on the ground to run and jump and move around a lot. And basically this is a tool in which potentially everybody should try to score as much as possible high to 100%. But it's also an assessment that is dynamic to change because it's able to capture changes. And what we were seeing is that it doesn't work that well, unfortunately. It works in a subset of the population, but in about 2/3 of the children that we evaluate, they perform below what is considered the floor, which is about 20%. And the GMFM88 is proportional to the AGS severity score. And so you see on the bottom right that actually the tool performs quite well if you have an attenuated phenotype, what is called a mild or attenuated phenotype. And also in the moderate cohort, there is about 50% of the population that is able to perform above the floor. But unfortunately, if you have a severe motor manifestation of the condition, this doesn't seem to be the best tool. We explored this first because this is sort of the gold standard, and we're now exploring other venues by administering different assessments or modifying this existing assessment to basically try to create something that is more specific for AGS. Well, that was what I just mentioned. And then one thing that I wanted to mention is that we're also focusing a lot on validation of remote administration of any assessment that we can remotely, because this was coming up for like the COVID-19 emergency, but actually we are really conscious about the fact that we are only measuring performance of children that travel at CHOP. We are conducting a selection bias. We're basically selecting people that are either able to travel because their condition is not severe enough to make them unable to move, but at the same time also it's economical constraint for families. And so we're trying to be mindful of that as well. And basically we were able to show that remote administration of the GMFM88 shows the same exact trends of in-person ones. And we are offering that as a potential possibility. When it comes to fine motor function, so manipulation, we use this assessment. It's called Peabody Developmental Motor Scales, and it's basically an assessment that is designed for children range 0 to 6 years of fine motor function. And actually we administer these outside of the range of validation just because we're really trying to capture the overall performance. And so we're only scoring the items that children are doing, and it's called normalizing by age. And what we're able to show is that there is quite a spread that is even more relevant than in the GMFM88. So we have a group of children that tend to have important impairment of the fine motor function, but in the attenuated group and in the vast majority of the moderate group, fine motor abilities are at least comparable to a child that is 4 to 6 years of age. And that's in about 50% of the individuals that we have evaluated. And so you see that in this study we included 74 individuals. And so this sounds very promising because we have tools for children that have an attenuated phenotype to be able to capture their function. So we can bypass the ceiling effect, but we're also studying alternative tools for children that tend to present a little bit of a floor effect at this assessment. Now we go into the more exciting part, which is the psychomotor development and cognitive function. So one of the things that we observed, but also that families were coming back to us all the time was, I think that my child has much more ability to understand than what we give them credit for. And so we tried 2 different types of assessment. The first one is a psychomotor assessment. The other one is a nonverbal cognitive assessment. And I will take 1 second to explain you the difference because it's very important. So when a child is very young, it's impossible to talk about cognition because the cognition is associated to a motor output. And so until the age of, there is a little bit of debate, but about 3 years, it's inappropriate to talk about cognition in a child. You can talk about psychomotor development, but then we enter into a bias. If I am evaluating the cognitive ability of a child through their motor ability, knowing that there is an impact of the motor ability, I'm potentially underestimating the abilities of a child. And that's exactly what we saw in the Mullen. So the Mullen shows that there is a tremendous floor effect in this assessment. There are some children that perform higher than the floor, and actually they perform within a range that is almost considered typical, but the majority of children that were evaluated perform lower than expected by the assessment itself, which again, it's expected, but then we were even, and these include 57 individuals, but then we tried another tool, the Lighter 3. So the Lighter 3 is a nonverbal, non-motor assessment that for answers only require a child to either point or look at an answer. It's a visual answer. And so again, there are some challenges associated with that because one of the symptoms that can manifest in AGS is like visual impairment, can be central or can be peripheric. But still, we wanted to try this because we had a sense that this assessment might work. And this assessment has another big advantage. It doesn't take in consideration what's your native language because neither the child or the providers speak. And the age range is different from the Mullen because the Mullen can be done in a child that is newborn. The Lighter, you need to be at least 3 years of age. So in order to complete the assessment, you need to be 3 years old or more, or have performance that is comparable to the one of the 3 years old, or a little bit less at the beginning, but then the requirement is that. And this is what we saw. So to guide you into the image, so what is considered a typical cognitive performance is 100. And between 100 and 85, you are considered intellectually, basically with a normal IQ. And between 85 and 70, you are considered with a borderline IQ, but it's not considered intellectual disability if you perform at an IQ of 70 or above. And so what you see in the left, which is a graph that includes all the individuals that have been evaluated, which is 59, and this includes also patients and children that failed the administration of the Lighter. You see that the median performance is 62. And so basically what this means is that about 50% of the cohort of children that have been evaluated perform at a nonverbal cognitive ability that is not associated with what is considered a typical intellectual disability. And then when we only consider the performance of individuals that successfully completed the lighter, which is on the right, actually the median performance is above 70. So it means that of the children that are able to complete this assessment, 50% of them or more are actually not cognitively impaired when it comes to a nonverbal cognitive ability. What does that mean? This means that these are children that have potential and that in a correct environment and in which they're given tools that they can use to bypass the motor limitation or the expressive limitation through language, there is the possibility of thriving. And this is remarked even more by the next assessment, that is an interview that I always conducted with families concurrently to the lighter, that it's an adaptive behavior questionnaire interview. And basically these explore with the parents what a child typically does at home. Because, as I mentioned before, performance can vary quite a bit. If I have a child that one day is not very happy with me, they're going to perform lower than expected. And so I always wanted to have a sort of a Linux sheet that I can use to basically try to understand what's the average performance at home. And this is a very busy figure. Let me explain you what does it mean. So on the figure on the left, you see the performance of children. And again, 100 is what is considered typical, and then 70 is impaired. Below 70, there is like an impairment. And communication abilities tend to be less impacted than motor abilities, quite dramatically less impacted. And then when we explore the difference between communication, between receptive, what I understand, and expressive, what I can say, there is a discrepancy. And so basically the receptive abilities tend to be higher than the expressive abilities. And even at the Vineland, we see that about 40% of the cohort perform have receptive language abilities that are above what is considered a disability. And these include everybody. So this is not bias by taking out individuals that have failed the administration, because it's impossible to fail the administration of this assessment. And you can see the spread of function. There is a lot of spread. So there is a lot of heterogeneity, but these assessments seem to be able to capture all the spread. And just the last couple of questions, and then I will end the talk. So we mentioned before about clinical trials and trying to understand how a clinical trial works. Because one of the challenges of clinical trials in rare conditions is, am I asking the right question to see if this clinical trial has an efficacy or not? Is what I'm looking really important? And so basically we conducted a clinical trial, and these are the results for after 1 year, and soon there will be a publication of the 5 years of the clinical trial. And actually this clinical trial used the AGS severity scale to show that in a population of children with AGS, the use of JAK inhibitor, baricitinib, was actually able to show ability to gain milestones at a quicker level and a quicker rate compared to what was in the year previous the use of baricitinib. And it's potentially true that these results might not have been captured without the design and the application of an outcome measure that is very specific for AGS. But again, we're also working towards determination of other assessments that tend to be a little bit more domain specific, so gross motor, fine motor, cognition, etc. And the final part of the talk was to basically try to give some ideas about what are the steps to monitor from a clinical perspective children that have, or teenagers or adults that have a diagnosis of AGS. And this is a slide that I I would say gently, I was like allowed to use by Dr. Adeng. And basically, this is sort of ideas for everybody to follow. So, like, because of potential blood complications with anemia, thrombocytopenia, a blood exam every year is potentially something to take in consideration, as well as measurement of the liver enzymes, because we know that children with AGS can incur into potential complications like hepatitis. It's important to do cardiologic evaluations about every year to avoid, to determine and rule out the potential risk of heart problems or pulmonary hypertension. It's important to do dental examinations because there is potential for dental decay, just because particularly in some children it might be difficult to provide appropriate oral hygiene, so it's always important to check that. It's important to evaluate swallowing studies to basically determine if a child is eating and drinking safely. It's important to check in general respiratory and pulmonary health, and this is something that doesn't need to be done by everybody, but if there are concerns for potential ab-ingestis pneumonias or recurrent pulmonary infections, it's something to take into consideration. And then in a specific subset of individuals that have a genotype same HD1, it's also important to conduct regular MRI studies to rule out the possibility of blood vessel complications like moya, which are known to be a potential threat in this population. It's important to do ophthalmologic exams every year to rule out the possibility of glaucoma. And then it's important to evaluate the genitourinary function about every year, particularly in subjects that have recurrent UTIs. And then it's important to evaluate bone health. And this can be done by either monitor IGF-1 in blood or doing evaluating basically bone age with X-rays. And then again, it's very important to do regular neurologic evaluations, particularly in children that have a progression of the condition or that are under treatment for spasticity. And then check the thyroid, because there are potential of hypothyroidism, and this is treatable quite easily. And then checking for skin condition, potential chilblains that can occur in anybody. They can be seasonal or year round, and particularly in individuals that have a limited mobility, rule out the potential of pressure or the pressure ulcers. And so, in conclusion, natural history studies are really the base of everything: outcome measures, clinical trial design, etc., etc. Without robust natural history, its design of clinical trial, it's basically doing in a blinded way, because you don't really know what you're looking for, you don't really know what to expect. You cannot even determine if something that you're observing is part of a potential evolution of a child that is untreated, or it's an effect of the medication that you're giving. And then the selection of outcome measures, it's an extremely challenging and complex process that takes into consideration a lot of variables. And basically the design of condition-specific tool can demonstrate efficacy in treatments that might be overlooked with traditional testing. And what we're seeing is that while the motor impairment tend to be present in a consistent number of individuals with a discrepancy between gross motor function that are typically more affected than fine motor function, but there is a clear subdivision between motor function and cognitive function, specifically if we take in consideration models that explore receptive language. And the struggle that we're seeing is that there is a very big heterogeneity of function, and so potentially in the context of a clinical trial we need to determine different targets for evaluating efficacy, because it's not a one-size-fits-all. We'll need to be potentially more precise in determining entry groups in the clinical trial, and for every different group, selecting a different endpoint for evaluating efficacy. And with that, I would like to acknowledge the support of everybody. We were talking before with Patrick, and it's like it takes a village. Potentially it takes like a megapolis to work on this, and to try to understand how to really design things that are appropriate. And the incredible expertise of everybody that is collaborating on this process is actually allowing us to progress on, and this will not be possible with the incredible support of the AGSAA and in general of all the people that participate to our study and share a lot of real life situation, like their background. Takes a lot of time, and we are extremely grateful for the support that everybody is doing in providing this project, and hopefully this incredible effort of everybody will allow us to push forward towards this situation, particularly taking in consideration this exciting situation for which multiple companies are getting interested, and there are potential different molecular treatments, and that these natural history studies and outcome measure selection are actually extremely versatile and can be applied to any potential treatment. So they are not treatment specific. This can be used within the context of clinical trial that explore the use of different therapeutic intervention. And with that, thank you for your attention.
Do I have a microphone on? Okay. So, Dr. Gavazzi, we got a question in the Zoom chat.
Mm-hmm.
On the AGS severity scale, are there age ranges associated with it? So, for example, for a child with a specific number in severity who's using JAK inhibitors, can we anticipate cautiously that the severity will remain stable or improve?
So, we have seen, we observed in the clinical trial that the vast majority of individuals were showing a stability or an improvement of different degree. We still observe some children that had basically a decline that was in that case associated with like a reacutization of the condition. So this is clearly a treatment that has some sort of efficacy and is able to prevent further damage, but it doesn't seem to be able to prevent in everybody a potential evolution. What we're seeing is that it was only in the first year of clinical trial, only one individual out of 35 actually experienced that. So that sounds promising, but it's not a 100% thing. So unfortunately, this is the state in which we are. We are now doing analysis in 5 years to get a better sense of long-term how good is baricitinib and this JAK inhibitor over time to avoid potential reacutization of the condition. And also there are going to be studies about dose and efficacy, because potentially also doses play a role, the dose of the treatment plays a role into the efficacy of it.
Okay, thank you. We've got another question here. He says it's from the previous presentation. I think I know the answer to it, but I'm going to ask you as well. He asks, how do we check if we're eligible for future trials if being on baricitinib will that prevent a family from being able to enroll in future clinical trials?
So that will depend on the inclusion criteria of the clinical trial. After the presentation that Dr. Adeng gave us today, this morning, about the new panorama and the new perspective of treatments in leukodystrophies, is that potentially we're not going to be in the scenario of having only one treatment for every one of the leukodystrophies, because if we have like 100 treatments and different molecules for diabetes or hypertension, and oftentimes you actually need to take multiple ones to manage a condition, is likely going to be the same for these other conditions. So it will depend on the design of the clinical trial, but some clinical trial design might allow you to take a medication and then you basically evaluate what is the evolution and the effect of the second medication starting from your baseline, because again we are going to do non-concurrent control arms, so you're always like the progression and the improvements or the changes over time are always being compared to your baseline and your pre-assessed evaluations. So this is the situation, but there will be I cannot give a 100% sure answer, because if the clinical trial is designed for individuals that have never received a medication, then that might not be the case. But the trend that we're seeing is trying to have multiple potential treatments.